we are starting with a session which we traditionally call the Local Government Academy. We will be talking about how local governments can support the healthcare system and, in a complementary way, support proven technologies which would benefit local communities. Because our program for today is very abundant, I would just like to say that we have another success that we want to tell you about in terms of educating local communities, where often we talked about the need to hold classes at schools with regard to healthcare protection and general health. And it's our success that such classes will actually be held. We consider it a success, and we'll see how it goes in practice. We'll see in practice how this will affect the implementation of the tasks about implementing health protection measures. We are convinced that this will be a beneficial impact. During our session, here with us in the studio, we have Jacek Siwiec from the Polish HTA agency, Professor Marta Podhorecka from the Mikołaj Copernicus University, and the Marshal Roman Kolek, who is the head of the Health Commission of the Voivodeship Association. We will also have Ms. Masłowska-Parafian connecting via the internet, as well as Mr. Marek Wójcik from the Association of Polish Cities. Unfortunately, Ms. Maria Pietrak-Frączek was unable to join us. There were some important issues which prevented her from joining us. Please ask your questions online on the chat if you are connecting online, and whoever is here in the room and wants to ask some questions, that we'll do that at the end. Now we have the assessing the efficacy of healthcare policy programs in local governments. My name is Jacek Siwiec. I'm the Vice Director at the Polish HTA agency in Warsaw. For 25 years, I have been dealing with the broadly understood quality in healthcare. I started my career in the Center for Monitoring Quality, and this is the institution where the first measures of assessing health policy programs were created. Obviously, the basis was for that was the Act on Local Self-Governments. Soon we'll have the 35th anniversary of that legal act. Professor Regulski, whom I had the pleasure of meeting, initiated those works. I might refer to him later on when I discuss specific tasks of local governments in terms of healthcare policy protection. The first such implementations were related to the Center for Monitoring Quality at the end of the 90s, and that has been a long time ago. We had the first order from the City Hall of Krakow. We were asked to prepare a report on the health condition of the Krakow citizens. The institution prepared quite an abundant report. They touched upon socio-demographic changes in the society. And as part of those reports, we also included some assessment aspects, assessing the actions taken by the Krakow local government. It was quite specific because this city hall took up the implementation of some actions specified in the aforementioned legal act, which included both obligatory and voluntary aspects. Another important moment in the history of implementing health policy programs, that was related to the creation of the so-called health need maps, based on the epidemiological data in Poland. First it was implemented in 2017, the next edition was in 2019. I'm mentioning this because the Polish HTA agency had a significant contribution to the implementation of this initiative, because we provide a contribution with regard to making a calculation with regard to the global burden of disease. This is an indicator which first was calculated for Poland in general. Now it is calculated also for specific voivodeships. It is an important part of the health need maps because the source of meeting or failing to meet medical needs, that's related to the needs presented in those maps. It is a very necessary, very important and necessary document. Our agency has also been very intensely involved in the area of health policy programs, while the relations and regarding assessing drug and non-drug technologies, this is quite rigid, and the agency only assesses what it is commissioned with. The agency is very proactive with regard to relations connected to assessing health policy programs. We have a website devoted to assessing and creating health policy programs. I recommend the resources which are available there. And another thing that is often used by various regions is the so-called creator of Polish health policy programs. It is very useful for both you and us. It shortens the time for us, and it helps you avoid any mistakes. Ladies and gentlemen, what's the origin of getting the agency involved into assessing health policy programs? It's quite a specific thing, typical for Poland. The agency has been included by way of Article 5, subpoint 29a, where we have clearly defined, it is clearly defined that only those programs can be actually implemented which we as an agency, which are considered safe and effective. And when you hear safe and effective, you obviously think of the agency. Now, just a short side story, side clarification. Our agency only rarely is dealing with certification in terms of quality. It is the tool regarding reimbursement at the disposal of the Ministry of Health, and most resources are devoted to that. We are not dealing with assessing the absolute value of an absolute quality of technologies, only whether they are worthy of reimbursement in Poland. We have some tasks which are some programs which are implemented on a national level, for example, prevention of HIV and treatment of HIV, and also local initiatives implemented locally by local governments. Ladies and gentlemen, from the perspective of our agency, point 3 in red is most important. So, implementation of new medical procedures and prevention measures directed at a defined target population with a for a specific disease or a specific health issue. And this is what our agency does. So the legal act involved us formally to carry out this task since it was adopted. In 2017, there was quite an important modification with a formal dimension. So starting 2017, the programs do not just need to be approved by our agency, but they cannot be implemented without the president of Achtapol's consent. So we not only provide opinions and assessments on the programs, on the draft programs, but we also, in a way, certify their implementation. We give the green light. And as part of our assessment, we do not evaluate in an in-depth manner the effects of the program, but what we do is we assess the draft. So if we have a certain pathway, if we have a well-developed pathway with a specific target, our assumption is that that target will be achieved. And now we reach the problem of assessing the final results and the problem of assessing measurements. It's difficult to do, in particular in issues related to medical aspects. It's all quite difficult and covered by mystery. So we are aware that measuring health outcomes is very often beyond the reach, the capacities of local institutions. The act of law that I mentioned also formally regulated the structure of the document which designs the health policy program, and the structure cannot be freely changed. If there is a change to the structure of the program, the president requires the agency requires the necessary adjustments to the program. The necessary elements of the health policy program includes, among others, monitoring and evaluation of the health policy programs. An element of that are reports prepared by the local government unit after the implementation has been completed. And we've got the template that is obligatory and needs to be used in the creation of specific programs. I will skip some of this information. And something that was introduced in 2017 as well. So what was introduced by Article 48A. So reference programs, template programs which are developed by our agency. So programs, the implementation of which outside of notification does not need a separate assessment. So if a government unit uses one-to-one our templates, a separate assessment is not necessary because we assume that the achieved results will be as expected. If a situation regards an extension of a given program, this extension, continuation of a program does not require our consent as well. If the technologies, either drug or non-drug technologies, remain unchanged, but should the technology adopted, should either the population or technology used change, then another consent of the president of the Polish agency of HTA needs to be issued. If a program was not developed in line with our template, the template which is included in the regulation, it is returned to the applicant and it needs to be corrected in line with the template. Generally speaking, all those actions are related to three elements. All are related to diagnosis, are all related to planning a change, and corrective measures, and a final assessment. So our assumption is that the actions that we take, will cause a change. Failing to provide this change will also be evaluated as a negative outcome of the program. What is also important is that the opinion of the president of our agency is a final decision. It's not possible to continue with the program, to implement it, without a consent of the president. There is no way to go around this. This applies to all levels of local authorities and all programs. Another important thing to mention is the final report. It is a summary, a qualitative summary of the actions that were taken as part of the program. The nature of this report is also specified in the provisions of law, and it includes clearly specified, defined elements which the agency expects to see in the report. The agency has then a specific time limit to carry out the assessment and to confirm that the assumptions of the projects were met. And the local government unit which implemented the program has only 3 months to draw up such a final report. For simple projects, simple programs, this is sufficient, but for large implementations, it is quite a challenge and requires quite a lot of workload. We will skip some of the slides. We also mentioned Article 48A, where we already have a template, a recommendation, a template report which does not require separate approval. It only needs to be notified. However, when it comes to creating such a recommendation, such a template, they are created as a result of a decision taken by the president of the agency, and here we have no time limits. If the president creates a plan for implementing such recommendations, then they are carried out depending on the resources available. But if there is an order from the Ministry of Health that a program is to be developed, a template, then the agency has 2 months to do so. An analytical report is created. The HTA report is the basic tool used by our agency. This analytic report needs to be created. Then specific templates are developed, specific requirements that later are going to be obligatory for the applicants. Then the project is assessed by the Transparency Council, and in the end a final recommendation of the president of the agency is issued. Have we created many such recommendations? Since 2019 we've had 19 altogether. They are obviously available on our website. You are free to use them. You're actually obliged to use them if you want to implement similar programs. I won't get into details, just let's focus on this year. Already this year we have managed to publish 5 different recommendations in very clinically complex issues which require quite a lot of preparation. Why it is important? We'll have a look at the statistics, because it shows how valid those issues are for the success of of the efforts taken. As you can see, there has been quite a lot of fluctuation with regard to the number of implementations. Obviously, in 2017, due to the amendment of the Act, we had a lot of such implementations. But even before, without such requirements, assessments of health policy programs were carried out, and we carried out quite a lot of them. In 2019 already, in 2009 we had the first ones. Then there was a certain natural saturation, which was to be expected. There were also disturbances caused by the COVID pandemic, and the number of those recommendations dropped. In 2023, you can see we have 93 and 75 such recommendations. What do they most often regard? So we have some main categories. Obviously, we have some specific ones, but the main categories that are most popular right now. Obviously, we have vaccination programs, so immunization preventing infections. They are often chosen by local governments. Local governments also are often implementing issues related to rehabilitation, but also oncology, which are more complex programs. In the years 2019-2024, there were a lot of such implementations. Most regard HPV, pneumococci, and influenza. This is the majority of the programs. And when it comes to assessing those programs, what you can notice is the third line. Those reports in red which were not subject to opinion because of formal shortcomings. Although the process is very precisely described and specified, still, and also the creator of the programs is available, the tool is available, still very often sometimes there are formal shortcomings. So we see the area for additional educational measures because formal shortcomings keep coming up. However, in view of the fact that we do have the creator tool, we have reference documents, most programs go smoothly through the assessment process. Oncology, cancer care, the area that I mentioned is on the rise when it comes to local governments getting involved. We have mostly breast cancer, prostate cancer, and colon cancer. Most programs regard those three types of cancer. And now the results of the assessments. Here you can see the outcomes are not the best. You can see how many negative opinions we had to issue. And also, most programs were not opinionated because of formal shortcomings. The lack of recommendations is clearly negatively correlated with the number of. So, and this is the case of all areas. If you have a look at the prostate cancer, is the majority are the negative opinions. This area seems to be something that requires more support. And from the perspective of our agency, we can see we have to issue a specific recommendations or a recommendation for local governments so that they know how to create programs regarding colon cancer prevention. Mental health and other areas. When it comes to rehabilitation, this is also an issue which we described in quite a lot of detail, so therefore the recommendations are mostly positive. To sum up, our agency plays a key role in the healthcare system, in the system of assessing health policy programs for two reasons. First of all, it creates the right tools and prepares the process. We provide the creator tool, we carry out training, we support the local government units. And secondly, the whole process is described in great detail on how to create the programs, and all issues related to the evaluation of the programs is also very specifically defined, which is not always the case in Poland, because very often the recommendations are too general or even contradictory. In our case, the situation is quite clear. We will be talking about this in greater detail maybe later on, but I would like to underline that the role of the agency is not just to evaluate, but also to somehow support the entire process. So our action with regard to our operations, with regard to health policy programs, is different to what we do with regard to assessing drug or non-drug technologies. That's it for me, but I guess we will touch upon some other topics during the discussion. Thank you for your attention.
Thank you. This presentation is an introduction to our discussion on the role of local governments. Actually, the presentation shows how important local governments are in prevention and in implementing health programs. I know that local governments are in dialogue with the agency and with a number of questions being asked, formal or substantive questions being asked. We cannot exhaust the full list of all the topics relevant for local governments and health. It is our intention to have a list of the most relevant ones every year, relevant in terms of healthcare strategy. That is why today we decided to invite our next guest, Marta Podhorecka, professor at the chair of geriatrics at the Medical College of Mikołaj Copernicus University in Torun, and is the head of the Senior Policy Task Force at the Ministry of Health. And she will talk about the senior policy, and she will try to show us how local governments can contribute to better care of elderly people. Professor, the floor is yours. Welcome, ladies and gentlemen. Thank you very much for inviting me. I'm really glad that we can discuss from different perspectives. We can discuss our health from different perspectives. I've been involved in health matters for 20 years. I'm a physiotherapist. I'm also involved in preventative products and the products to prepare people for elderly age. I will try to show you that the elderly age and the preparation for older age are not typically linked to health only. Let me start from the very beginning. What is senior policy? Senior policy officially speaking, was elaborated last year by the Ministry of Health. And this is the unique case in Poland and also in Europe. In our group, we developed the senioral policy. The senioral policy is focused on the elderly now and in the future. In other words, we need to adopt a long-term thinking. The senioral policy covers healthcare, social welfare, digitization, plenty of topics to be integrated. We are actually a very young body, and which brings together a number of experts from various fields, and I believe that the future is bright for us. Why older age is so important? Well, we've been witnessing global society aging. Just think about it as an opportunity more than a challenge. We have a lot of elderly people in our societies. This means that our quality of life has improved, healthcare has improved, immunization has improved, pharmacology has improved, and the changes in our lifestyles. What are the forecasts? According to the National Statistical Office, in 2050, elderly people will make up for 40% of the population, so almost half of the population will be above 60 plus. And we will have a lot of friends then. Just don't forget that these people will need to be taken care of. Let's have a look at the demographic pyramid, which is reversed, starts to reverse, and the birth rate is reduced, and the life expectancy is prolonged. And there is a sort of a double or triple aging, with more and more people aged 80 plus or 100 plus. And we have a group of people 80 plus with children who have already retired. So whole generations of people in this 60 plus group. The healthcare policy is of key relevance here. It's about the promotion of healthy aging, prevention of diseases, and support to autonomy. I believe that the patient, the human being, needs to be empowered, and the awareness should be raised in the field of healthcare. That is why the Polish Ministry of Education decided to create new programs in the core curriculum, and we actually submitted our own position. It is about preparing the young generations for the healthy older age. Well, let us move to the population of seniors. This is a very diversified population, 60 plus, 70 plus, 80 plus, 90 plus, or even 100 plus. I must say it's really hard to define the population. Usually these people have some comorbidities, 2 or 7 comorbidities. In this group you have patients who are completely autonomous or completely dependent on their caretakers, well educated and with a primary education only, living in large cities or in small villages. So each program needs to be tailor-made. What are the key elements of the healthcare program? Dedicated to seniors. considering the comorbidities and the need to make an audit, pharmacological audit. Actually, we have plenty of patients with many comorbidities, heavily medicated, and these audits improve the quality of life. Plus, add to that the pharmacoeconomics issues. And for the future seniors, we need to do our best to make them as healthy as possible. What can be done? First of all, access to healthcare. Under this goal, plenty of solutions have been developed in telemedicine. If you review the literature, you will see, as in this article, the following findings. So there was a sample of 1,245 articles, and 10 were selected as the ones with the most robust methodology. And the findings were as follows. Telemedicine may improve access to healthcare services. That is why we need to think about digital exclusion. It's because of the lack of access to internet and very poor digital skills among the seniors. That is why, in order to reduce these exclusions, we work together with the Ministry of Digital Affairs. Especially that telemedicine may be an excellent tool to fill in white spots on the map of Poland. Let us move to the next pillar, preventive actions with bracelets. Have a look. We have people with cardiac insufficiency, severe cardiac insufficiency, with recurrent visits to hospitals, and they got special bracelets with the monitoring software of vital functions. And after 1 month, there were no differences between experimental and control group after 1 month. However, after 6 months, there were less side effects or adverse effects. In the control group was higher than in the experimental group. This was the study done in Australia, and the savings were of 100,000 Australian dollars. So a tangible and measurable outcome and effect. True savings. Third pillar, physiotherapy. Here we have a new program for 70+ patients. The program was intended to promote physical activity, like exercising, standing 3 times a week. And the researchers counted the fall. In the first study, we had no differences between the two groups. And actually, scholars were skeptical about the continuation of the study, but after 2 years, in the sample of people 70+, so after 2 years, the number of falls was reduced by 20%. And the fall among the elderly population is a key issue, which, as part of the domino effect, leads to the lack of or loss of autonomy. I would like to encourage you to make some reflection. Just have a look at this quotation. One of the professors wrote a letter to Lancet. I translated that quotation. Imagine a condition that makes a person irritable, depressed, and self-centered. and is associated with a 26% increase in the risk of premature mortality. Imagine too that in industrialized countries, around a third of people are affected by this condition, with 1 person in 12 affected severely, and that these proportions are increasing. Income, education, sex and ethnicity are not protective, and the condition is contagious. Such a condition exists. It's loneliness. Yes, ladies and gentlemen, the loneliness of the elderly has a major impact on their health. A bulk of research has proven that the loneliness will increase the risk of dementia by 40%. And, as I've just said, the risk of early death increases by 26%. It's enormous. What can we do? Well, just have a look at this study. This study shows the role and impact of intergeneration programs. 27 different initiatives, volunteer programs, artistic classes, intergeneration discussions, number of different events. What are the outcomes of the study? For the elderly, their mental health has improved. They have become more socially active. Their life became more meaningful. They developed socially and emotionally. For children, basically there was a better understanding of what the elderly age is. For now, children actually and youth do not live in intergeneration families, and they lose of sight the elderly age. They don't know what the elderly age is about. People with dementia or people suffering from depression also benefit from such programs. If there is no option to implement such initiative, you can use robots. Just have a look at this feed. A seal, a pair of seal, a learning machine used in one of the elderly home cares in Sopot. And actually, people living there in this home care center love this animal. It may seem strange, but the studies clearly show that this works. We have also patients with cognitive disability, neurocognitive disabilities, dementia or Alzheimer's. More and more cases have been registered, and if we have a patient like that, we need to think about the whole family. Well, every disease involves every family, but in the case of dementia-like diseases, there is a higher risk for the family to feel a burnout and the stress of the caretaker. Just have a look at these studies. We have no solutions in Poland of the kind. Let's say that there is a diagnosis, the patient hears, listen, you've got dementia, early stage, and it's basically done. He's done. There are no programs targeted at both the patients or the caretakers and families. If the neurocognitive disability is mild, and people with such disability undergo training, their autonomy, they will stay autonomous for longer. And it's all about autonomy. It's to empower the patient and to make the patient less dependent on any third parties. Have a look. This study is about the access to an online platform by informal caretakers. The same platform brought together the support groups and included guidelines on how to communicate with the dementia patient. So as you can see, the platform offered a number of support tools, and people who used that support suffered less burnout and felt better in their role of caretaker. Add to that, mindfulness training for informal caretakers. I think this could be a good idea for local governments. On the slide, you see the meta findings. According to them, caretakers who underwent mindfulness training coped better with everyday life and the care. I remember our training, 1 week training for caretakers organized in Bydgoszcz. We met every week. We could not do it over the whole week because nobody could afford that. And they met over 6 months, and now the group has stayed, and this is a group of mutual support. And moreover, we had a matrimonial success as well. I believe that when you think about the future of the seniors, you need to be aware of how important professional activity is. Those who stay longer on the labor market and are professionally active are less exposed to the risk of dementia, have better vitals, and we all also see those cases of people who retire and just sit in the armchair and stop to be so active. Yes, there is also a group of active retirees, but they account for only 3%. For cognitive functions and for physical stamina, it is important to do everything to stay on the labor market as long as possible. The Senior Policy Council will now prepare some new proposals of amendments to the Labour Market Act. Actually, the retiree cannot register at the unemployment office as a job seeker. This has to change. The next study, a sample of women, and the study has shown that the regular work at a younger age has an impact on positive life outcomes at the later age. This is surprising. Even if these women didn't like the job, still that job had a positive impact on their life. And is something for you now, example of comprehensive good practices. Germany, care insurance. Every adult chips in order to have a budget for providing care to the elderly. Japan, a comprehensive senior support program, telemedicine, psychological support, rehabilitation. Actually, the Japanese would take a different approach, and the image of the elderly differs as well. The elderly in Japan are basically people who have experience, who are savvy, wise old people. I think that this mentality change is also needed in Poland, Denmark, telecare, e-care. I think that we follow the steps of Denmark, but we have something to catch up with, and that would be a good solution for the generations to come as well. What is the role of local authorities? I believe that the role is huge. The role is huge in terms of support to the elderly people, especially that you have a better understanding of the needs of your population, of the local population, people living on the territory of your community. With that, you can have a more tailored initiatives to help the seniors today and in the future. Education, social awareness, health education, everything to raise awareness that everyone is responsible for their own health. Social activity, prevention of isolation at home. I don't know if you know that Turkey has a special program, and every residential estate has one coffee shop. And if you are a senior and you have the ID card, you go there and you can get 1 cup of coffee free of charge every day. Plus there are playgrounds, and seniors can go there with their grandchildren. So, you know, there is a platform of interaction. Transportation. Well, mobility is an issue because you need to transport the patient for occupational therapy, for doctor's consultation. It's of huge help and need. What other good strategies can I quote? Well, let's say Gdańsk. Active Seniors, a program which offers free of charge physical exercises, plus education and social activities. Usually the queuing time for such classes is long, but the physiotherapy is a must for the silver population to be active, and you don't have to go to the outpatient clinic or the healthcare facility. Sometimes can be a culture center in the community with some exercises, or with the talking hours. And Gdańsk offers such a program, and there is also a ranking, and there are different culture clubs and community clubs competing for the place in the ranking. The second strategy is about the transport of seniors. I've mentioned that already. Many would say that we need some systemic solutions to test the silver population. Are they still capable drivers? Yes, and some seniors are no longer capable of driving, and if this is the case, just provide them the transportation to the places they need to go. And third strategy, local telemedicine. Here I would like to describe a program I'm involved in. It's a telecare in the Kujawsko-Pomorskie Voivodeship, north-west of Poland, with more than 300 seniors with bracelets and audited neuro, cognitively, nursing, home conditions, a physical audit, just to see the true life conditions. What is problematic is the shortage of staff. So, we relied on Scandinavian examples. There, the students of the last year of medicines are chosen to do screening tests among seniors. For future nurses, it's the 3rd year of studies. For physiotherapists, it's the 5th year of studies. They actually are already able to do the screening and surveying, and this is beneficial for both parties. Students have contact with the patient and can practice. The patient can talk to some younger people, and the organizer actually is also winning because they don't have to recruit the professional staff, which is not available for financial reasons or for time reasons. This program will start soon. All the audits have been done. The recruitment is underway, and I do hope that one day I will be able to come back and talk about the results. I'm also a teacher, and because I'm a teacher, I want to repeat one thing for you to remember. And I just prepared some rules, key rules to be followed when devising a program. I think this is a sort of a list of hints and tips for health programs. So, P, prevention. Focus on prevention, but understood broadly. R, recovery. Recovery of physical fitness after some event or hospital stay. O, opportunities for today's and future seniors. It's not about educational classes. There are people who do not like to take part in so-called third age universities. G, growth. Promotion of growth, including at the professional level. R, responsibility, learning how to become responsible for one's health. A, autonomy, staying autonomy as long as possible. M, modern, implementation of innovative solutions in healthcare programs to improve access, efficacy, and to reduce costs. And at the end, I would like to give you an example of a very nice meme about the older age, one of my favorite. Thank you very much.
Thank you, Professor. I think that this presentation should be displayed at all meetings of local government councils, at all levels of local government authorities, because this not only discusses the whole subject matter in a very comprehensive manner, but also the presentation indicates specific examples which can be of actions which can be implemented ad hoc, which can be quite easily introduced locally. Thank you for this. Now we will shift a little bit the order of our presentations. That's why, because we whispered a little bit, because some of our speakers are a bit busy. This includes Marek Wójcik, who is a representative of the Association of Polish Cities, who is right now in the Polish Sejm, and he is motivating the authorities to take the right decisions and make sure that the government does not forget about local governments. So now Marek Wójcik will take the floor. We are always really happy to welcome you at our symposiums, despite of you being so busy. The past, the current time, and the future of health policy programs, from the perspective of local governments and from the perspective of the Association of Polish Cities. The floor is yours. Hello, ladies and gentlemen. I hope you can hear me well. Please give me thumbs up if I'm well heard. Good. I'm really happy to be able to meet you today. I mean, same right now where another sitting will be and another vote will be held. We'll be voting on some initiatives which we've been discussing in the last days and which require fast action, including reacting to the recent floods. I want to start my short presentation with a short thank you and showing my gratitude to everyone who is willing to take the necessary initiatives. I have two observations. One is that you are a group which unfortunately is a bit hermetic, so it's this group doesn't grow. New members don't really don't join the group. I will show you what I mean, what the situation is currently with regard to local government health policy programs. As local governments, we are And in this specific time, we are talking about new modes of financing such initiatives. The new solution is supposed to take us forward. The first year of this new system, 2025, will be a year of great changes, which is a good thing, because the decisions about who will get the funds results from many factors, and if we have the choice of how to make the determinants as good as possible or guaranteeing the best baseline funds for local governments to start with, we chose the second options because the determinants sometimes are hard to accept. We will be amending that, but we wanted to start with a good baseline. I'm talking about these incomes because I carried out an analysis. I don't know if you will be able to see the slides. I will try to. So this is a printout of a slide. I'm not sure if you will see it. So I think that's the best we can do. This is the expenditure of local government units spent on health policy programs in the years 2010-2023 in thousands of Polish zloty. You can see that time flies and not much is changing. In 2010 we had 82 million Polish zloty at our disposal. The same level more or less was until 2019. Then we observed an increase to 110. COVID brought us back to the 80s, so 87 million recently. So when I look at last year we had 126 million Polish zloty. When we referred to the costs and the remuneration of healthcare professionals, which are on the rise, we are dealing with an actual, so in realistic terms, the funds that we have to implement the programs have been on the decline. I have been observing this since 2010, and in theory, the funds have increased by around 50%, but realistically, it has dropped by 200%. So the purchase power of the funds that we have at our disposal has been reduced twofold. I would like to use this knowledge and wherever you can tell the decision makers we have to change it. It's high time. Another thing is that certain cities that are also powiat based are helping the situation a little bit. Some of those cities have additional budgets. There are some voivodeships since 2010 have been increasing the outlays around 30-something million Polish zloty a year of additional funds. But so the amounts that are realistically available are far too low. So some cities help out local governments. From the perspective of constitutionally guaranteed access, this is not good. So this increases inequality. This is not an accusation, it is stating the facts that currently we are talking about huge deficits in local governments, which is reflected in the health policy programs. I have prepared a comparison of how much we spent on prevention programs versus the costs on treatment borne by the National Health Fund. So another thing another chart I will try to show you. I'm not sure if it's going to be visible in this form, but what I want to say that this is information about how much we spend on Polish policy programs versus our entire spending, including education, logistics, and all that. I'm not sure if it's visible, but please have a look. That might be the best we can do as of now. In some cases, there is a huge decline. This proportion is very telling. How much we managed to somehow grasp for and allocate to this program compared to other objectives. In general, we had around 0.4% spent on health policy programs. That was in 2015. Now it's 0.3%. But the largest decline is at the powiat level. I regret to say that we have been observing a huge decline of funds for such health policy programs. In the past it was almost 0.5%, now it's around 0.1%. So when it comes to outlays on health policy programs, the powiats, this is something that a few years ago was unthinkable, because the powiats used to be the leaders in implementing health policy programs. I remember that since the powiat administration division was created, powiats were the driver of introducing such initiatives. It's no longer the case. All local government levels have been noting a decline on the available funds for health policy programs. So we are experiencing a regression. We need to keep convincing the government that all the taxes, like the small alcohol bottle tax, the sugar tax, those initiatives is not enough. When it comes to one national program to combat osteoporosis, that 100 million Polish zloty was allocated. That's more or less the same as numerous other local programs. One or two good government programs would, if those funds were instead redirected to local governments, it would do more good. Now coming back to combining our funds with funds of the National Health Fund, I've been noticing a trend which is also negative. In general, I am an optimist, so right now, and I'm afraid I need to be realistic, so the information I'm conveying is negative. We are observing huge polarization, polarizing tendency. There are some local governments which are doing really well, but when I meet the authorities of National Health Fund, they say that there are less applications that were submitted. So currently we are at a stage where the applications for 2025, those applications have already been submitted, but you can prepare for the next year. Do submit those applications. In the Parliament, there are a lot of projects which regard prevention. I've counted 31 teams which deal with health prevention, but this does not translate in any way to improving legislation. I don't have good news. I mean, there is a light at the end of the tunnel. There are some works which have been started to amend the Act on the public health. To be philosophic about it, everyone has what he deserves, what he earned. But the situation is that during the works on that act, there were supposed to be no members of the local government. Then they came up with one spot for a consultation. We are still fighting for more representatives during those consultations, during those works, because we need more representation of local governments at this effort. So we are expecting this amendment of this act. I hope that the amendments will be introduced, including how financing is provided for local government health policy programs. When it comes to coming back to the finances, I keep encouraging to use the so-called citizen budget, but I've been happy to notice that at all levels we are observing grassroots initiatives to promote prevention, health prevention. Use the options that you have. Also in rural areas, it's a good way to get what you need. A bit about the future now. I want to point your attention to two elements. First, mental health, mostly mental health of young adults and children. Contact mental health centers and, using their potential, carry out preventive measures. We've had some pilot programs that have been deeply rooted and have been very efficient. It's a great practice to cooperate between the mental health centers, between schools and the local government authorities. Schools need to be supported in the introduction of such efforts. This is a solution I recommend you copy. Second aspect, primary health care facilities. Coordinated care is a chance for us. 38% of primary health care institutions have signed contracts to provide the so-called coordinated care. There are some disputes, but this coordinated care provided by general practitioners gives us the situation that in the case of a relation with the patient, we have just being in contact, the GP with the patient, there is the prevention element. We can help solve a problem mentioned by the speaker before me. So the shortages of healthcare professionals. Primary healthcare professionals want to cooperate with us. It is in their best interest. One change, especially for senior citizens in terms of prevention efforts. Starting July last year, something called the nursing consultation was introduced. So nurses have more powers in terms of wound treatment and urology. There is an additional procedure, so 10 home visits. This is something that was introduced, and this is something which is being built on. We should take this example, maybe expand this. In general, we should get into contact with nurses and cooperate with them, engage them in such initiatives. And coming back to the flood, thank you for what you are doing in the flooded areas. We are trying to achieve one important thing. It's not easy, I have to say, but we're doing our best. The funds from the alcohol tax and the sugar tax could be allocated to actions remedying the effects of flood, including those affecting health aspects of the population. We want to introduce this solution in many acts which will affect responses to the flood, but also using this legal basis, other municipalities also not affected by the flood could maybe use the funds from the sugar tax and the alcohol tax on health prevention initiatives. We should be concentrating on issues related to, for example, vaccinations. Here we are observing an improvement. The last few years have given us various changes, but also we should concentrate on the elderly, on the less independent citizens, and also initiatives focusing on children, including with regards to mental health. There's a lot to be done in this area. Sorry for being so brief about some aspects. I regret that I was unable to be here in person. I hope that next time it will be possible. Thank you for everything, and if you need any clarifications, I will be available later on. Thank you. We are keeping our fingers crossed, and we hope that you are in good shape and you have a lot of strength to negotiate with the government. And I do hope that some of your famous optimism will be there as well, as you are known to be a strong optimist. Thank you for those words. We as CESTA who are tightening our cooperation with the Association of Polish Cities, and we will be carrying out actions on site in a hybrid mode and as part of workshops and online. There is a lot of things were said regarding finances.
There are plenty of ways to get extra financing for prevention at the local level. And EU funding is one of such sources. Edyta Masłowska-Parafian represents Łukasiewicz Innovation Institute and iTech Center as the deputy head of operations. Right now we are just ahead of the new financial perspective at the EU level. We had local elections, and you are all encouraged to ask questions. Financing of healthcare policy programs under the EU budget. That would be the topic of the presentation. Thank you. Thank you very much. Thank you for inviting me. It's a great pleasure to talk to you about the EU financing. Under this financial perspective, the budget is important, more than 153 billion zlotys. That is 44% of all EU money allocated to Poland is now available at the voivodeship level. We are just at the beginning of the road, and now it's up to voivodeships to see how to divide that money. Company development, better access to education, health protection and culture, better social infrastructure, environment, digital technology, energy and transport. All those initiatives can be financed with this envelope. Regional healthcare programs can also be funded in this perspective, we can use the lessons learned in the previous perspectives. And the procedure is quite similar. The money is paid under the regional healthcare programs developed by marshal officers at the regional level. The program is first submitted for assessment, and if the assessment is positive, there is a call for proposal for specific local government units. What type of measures can be implemented here? But important health issues at the level of the region, elimination of health risks at the workplace. And that's a major difference. Before, only employers could use the money. They had to make a occupational risk analysis, and based on that risk analysis, they could produce an occupational health plan. This time, under this perspective, the same can be done by the employers and by the local governments, and some voivodeships have already opened the calls for proposals under the regional healthcare program. The occupational risks are actually quite common and easy to categorize. So if an employer spots a specific set of risks, they would need to choose another, more specific call for proposals. That would be two types of measures. Then the third, medical rehabilitations to facilitate the return to work or to keep the employment. That's the type of measures targeted at people who stay on the labor market or already employed. The regional health programs need to be compliant with the strategic documents of the specific voivodeships. The analysis has to be made regarding the specific target group. The HTA agency highlights today that these needs to be done in order for the program to be positively assessed. The program needs to be fine-tuned and to the needs of specific region or voivodeship. Under the present financial perspective, we focus on white spots. If there are white prevention spots in some voivodeships because there is little access to healthcare and there is the high incidence of some diseases, the local governments can request for the financing to coordinate the healthcare, to train the primary healthcare staff, to improve access, to improve coordination of the healthcare services. It's not about the financing of health care as such, it's about education, awareness raising, coordination. And the Ministry of Health has provided a precise list of what can be financed under the regional health programs. Such programs have to be consulted with experts from specific area of knowledge to make them even more and better adapted to the needs of the beneficiaries. It would be advisable to use the experience of other local governments. The studies from the previous financial perspective, 80% of the programs got a positive opinion from the HTA agency and got the financing from the EU budget. So we already have a database with programs, positively opinionated programs, and I will show you some examples in a moment, just to illustrate that there is a stable group of needs, occupational diseases, other diseases, unmet needs, and so on, is quite stable. The patient should be taken care of in a comprehensive manner. In other words, a sort of coordination is needed. So you just establish a coordinator as a sort of a single contact point for patients who can call, make requests, ask questions. The intervention should also be part of the program. It's not only about or just guaranteed healthcare services. No, the measures need to be broader and more comprehensive, going just beyond the intervention itself. The valuation of services should be based on market rates. This is an issue. I know that because budgets are limited and it's not easy to define the unit price rate for a specific service. I've developed some programs which got the financing, and I know that if the rate is too low at the level of planning, it becomes really hard to find specialists or experts at the later stage. The program has to have a set of education measures, and it has been stressed many times today. These education and prevention measures need to be strongly promoted. And the program has to have a specific timeline. I stress that because if the program does not include one of that item, it is not easy to implement it. So it's the question of realism. Based on that program, you will produce an execution or implementation request. So let me now give you some good practices. For instance, preventing severe pneumonia and post-influenza complications in cancer patients. Program for improving maternal and child care or prevention of tick-borne diseases. As you can see, these programs are quite comprehensive. If you have a chance to include the element of prevention along with the screening, that would be good. Preventing severe pneumonia and post-influenza complications in cancer patients. With the most common tumors and blood cancers, healthy aorta, cardio-oncology, program for prevention of heart failure in cancer patients, rehabilitation programs post-COVID, cardiological, oncological, and medical, or regional program for prevention of civilization diseases such as diabetes, overweight, and obesity, and so on and so forth. The evaluation studies have shown that these programs were not comprehensive enough, that just blood sugar levels testing and screening was not enough. That apart from screening, you should also include a sort of nutritionist consultations or culinary workshops to help people change their eating habits. So again, I repeat, it should be comprehensive, it should include prevention measures. I remember the question from yesterday about financing the equipment and the infrastructure, but that's a very, very rare case, but I do have experience from the previous perspective. The colon cancer program had the plan to buy the equipment for screening tests. This infrastructure, healthcare infrastructure, is financed under different funds. European Social Fund is used to finance prevention, while the European Regional Development Fund will be used to finance infrastructure, so that different measures and the different calls for proposals. And indeed, there is a separate budget for that, and I know that the first calls for proposals have been open in Podlasie. There is a call for proposal for improving infrastructure in primary healthcare, and the value is quite high, 36.5 million zlotys. And in Małopolska Voivodeship, there was a call for proposal for rehabilitation measures, around 11 million zlotys in the budget, including infrastructure. As you can see, quite important envelopes. I'm a huge proponent of the EU financing and the use of EU financing. If it's made available, just don't hesitate and use it. It's an extra money, and local governments and employers can simply use them. Well, depending on the applicant, you will get the level of co-financing of 80% or 90%. It's important as well. So with little money from your side, you can develop and promote the programs of value for your regions and for your areas. Thank you very much. That would be all. I cannot move to my last slide. Well, that's my last slide. Thank you again for your attention. If you have any questions, I'm ready to answer them.
Thank you, ladies and gentlemen. Thank you for this presentation. If you have any questions after those presentations or after the entire symposium, we will be happy to provide you with to contact you with our speakers. Thank you for this presentation. We also encourage you to use European Fund when it comes to prevention and health promotion. Now it's time for my short presentation. I will squeeze it into 15 minutes so that we have time to hold a short discussion. The time we had for the local government academy was too little, unfortunately, but we are always limited by time constraints. We are now going to discuss in general our campaign Poland Free of HCV, and I will present a few model health policy programs which were created recently. This is the list of our cooperation with local governments and the various tools we developed. They are quite. The list is quite comprehensive. Last year we worked, for example, to develop osteoporosis prevention tools, also prevention of pneumococci infections in cancer patients. And our latest actions include prevention of HCV infections, diabetology, and TB prevention. Yesterday, we held workshops at our first day of symposium. We had a Q&A session directed at Mr. Tomasz Tatara from the Polish HTA agency. I think a lot of your doubts were explained during those workshops, so you can see a record of that. And now I will present the objectives of the campaign to eradicate HCV. Poland free of HCV, the assumptions are that chronic inflammation of type C hepatitis has not only medical consequences but also social and economic consequences. Currently, we do not have well-developed systemic solutions with regard to testing for HCV infections, even though the treatment that is available is very effective. So one of the most urgent needs to eliminate HCV, to eradicate it, is to make testing more common. That is why we took the decision to launch a campaign which would bring together all stakeholders, both local governments who already have experience, as well as various patient organizations and other stakeholders. This is our objective for the year to come, or maybe 2 or 3 years to come. We'll see how it works. Yesterday we discussed how long it would take us to test all the population if we engage also the local governments. The main tools is the update of the health policy program and presenting practical aspects of the new solution during a workshop. We also created a website, the address of which you can see on this slide, which includes resources, so educational materials that are downloadable, who can be also given to the beneficiaries of the program. We will be presenting epidemiological data which will help us evaluate the number of people in the program. We will have an epidemiological calculator and a barometer of the objectives of our campaign. The campaign is in line with WHO objectives in terms of eradicating HCV infections as a threat to public health. In Poland, over 110,000 people are infected with HCV. These are the estimates, and 70% of them have no idea that they are actually infected, and the infection is detected accidentally, by chance. Usually people the typical patient with this infection is usually still professionally active and is in his 40s or 50s, and in nearly 100% of cases it is possible to cure this affliction. It is a of huge importance to identify those cases. That is why we will be testing people. And furthermore, our program is in line with the recommendations of the Polish group of experts on HCV. This will include more broad testing in both hospital settings and in primary healthcare facilities. We want to allow local governments to choose a pathway depending on the local preferences. So one solution is introducing testing in hospitals, both in emergency departments, where a lot of people have their blood drawn anyway for lab tests. Then you just need to tick another box to test for possible HCV infections to see if the patient has the antibodies or not. You can also introduce rapid cassette tests for plant admissions. So educational measures can be started, if need be, already when the patient is hospitalized. Also during occupational medicine testing, this is something which could be an aspect of testing. This could be financed by local government funds. Those tests are not expensive. The cost of such a rapid test is around 5 to 10 Polish zloty. Using it takes 2, maybe 3 minutes. So our understanding is that it will be not very time-consuming or resource-consuming, and it can help solve very significant problems. Occupational medicine professionals have often participated in similar actions. They performed additional tests, and we know that this is an effective measure. Another option is introducing testing in primary healthcare facilities outside of the so-called delegated budget. There can be additional funds allocated to this measure from local government funds. Here we have a list of patients who are in the risk groups. This will be included in the calculator, our epidemiological calculator. Our anticipated results is reducing the risk of infections in the general population, increasing the number of detected infections, increasing awareness in the general population, and educating the healthcare professionals. What are the long-term goals? On the 24th of July 2024, on the Global Day of Hepatitis, we had a meeting in the Polish Parliament where we discussed long-term objectives, when we discussed the fact that we could have an improvement of the current situation by way of testing either all admitted patients to emergency departments or planned admissions, and introducing the obligation to test for HCV upon admission to drug programs. Currently, only 33 of the existing 133 drug programs test for HCV as an eligibility criteria. Also introducing in primary healthcare, introducing to occupational healthcare, and this can also be done in pharmacies. This is our roadmap. That's where there are different stages at which you can join us. You can find examples on the website that I already presented on the slide. Another topic is diabetes prevention. The reasons why we are taking those actions are obvious. No matter the variant of the forecasts, the incidence of diabetes will be on the rise. Local governments are taking various prevention measures to prevent diabetes. These are some statistical data. So why don't we have sufficient programs? What are the causes? We analyzed this, and it turns out that a lot of local governments, on the level of voivodeships, for example, did allocate a lot of funds, over 90 million Polish zloty. Those programs were opinionated positively. However, most of those programs were very standard. The find risk survey, maybe fasting glucose tests. Those programs were not particularly popular among beneficiaries or organizers. So we need to change the paradigm with regard to caring for diabetic patients. We have to think about how we can make those programs more attractive. Let's have a look at a few examples. Of 7,000 potential participants, less than 400 actually took place. In Śląskie, the program was not implemented at all because the interest was so slight. Of the planned almost 15,000 participants, less than 1,000, so far less, actually did take part. So something's not working. We have to make it more attractive. And how can we do that? How can you make this more attractive? Diabetes prevention is not as boring as maybe it used to be. Now we have more modern solutions and we can engage patients more. There is some space for improvement and for more multidisciplinary behavioral interventions. In newly diagnosed diabetes and in diabetes which is not managed, which is managed using oral drugs. More about that we will be presenting in October and November this year. The last topic is we started cooperation with WHO Poland regarding TB. I don't know if you know who this is. This is President Małgorzata Czajkowska-Malinowska, the president of the Pulmonary Association. With her and the experts in her association, we took up the challenge to create a health policy program, which is for a template for local governments, which is to help detect TB cases in risk groups. This regards educating the general population and risk groups and creating tailored educational materials. This includes also educating the healthcare professionals. It is very important because reports show that medics have forgotten that TB is still there and it can actually affect many people. For example, people facing homelessness, but some other people as well. This also includes testing people in risk groups, and we also will provide materials for clinicians. At each stage there will be a roadmap available on a dedicated website. There will also be an epidemiological calculator available. Please follow our newsletters because the program has almost been developed. It's just waiting for the final brushes, and we will be publishing it soon. There will be a dedicated website. Remember, TB remains a dangerous disease. We are reminding people of what the risk factors are and what to do if people do test positive for TB. Now moving on to another topic before we move on to the discussion is our program Pneumo Onco already has been developed. We have developed a program for the capital city of Warsaw. It enjoys an positive opinion of the primary agency for I've managed to fit into 15 minutes. I've won the bet, and now we are moving on to the discussion. Do we have questions from the people in the room?
The Council of Transparency. Professor, thank you very much for this, your insightful lecture. You've actually forgot one thing about the seniors. There are cognitive disabilities, but there are also physical disabilities, and we all know these expressions, slaves of the fourth floor. We all know what I mean. But I was told that 90% of seniors are digitally excluded. Is it true or false? And is there anything that your task force is going to do to reduce this digital exclusion? And what about hardware and IT maintenance? Do you do anything to ensure access of IT maintenance stuff for seniors? Thank you very much, Professor. I didn't have enough time to tell you everything. It's true that the people who get stranded on the fourth floor, especially that if you have a building with 4 floors only, you usually don't have a lift. And it's true, a lot of seniors simply don't go out. If you want to take care of the senior, you can organize a telemedicine or audio services, but the face-to-face contact is necessary as well. So you need to find the middle ground for digital exclusions. As far as I know, a number of measures has been planned. First, intergeneration schools. At school, the door will open for seniors who in the afternoon will have classes, IT classes, and even the young students can teach them. This is an excellent intergeneration initiative, and it will start really soon. During our last session of our Senior Policy Council on Wednesday, I met one of the heads of departments at the Ministry of Digital Affairs, and we agreed that some new joint initiatives will be launched to eliminate digital exclusions. So we are just at the beginning. Thank you very much for this question. Thank you. Before giving you the floor, I have some important question to Marshal Roman Kolek from the Union of Voivodeship of the Republic of Poland. So what is your approach to healthcare programs after the local government elections? Well, let me start by thanking for inviting me. It's a group of repute, and thank you for giving me the opportunity to listen to your insightful conversation. This is sort of a psychotherapy for all of us, and that's how I see it. And only after relaying this information further and further, we will be effective in action. I also wanted to thank you, Professor, for your senior policy lecture. It's important what you say. We've identified a number of dysfunctions regarding the senior policy. If you have a holistic view on health, you have the HTA agency, but apart from HTA, you need to assess social aspect, economic aspects. And this is important, especially if you want to use the EU financing. You can have the health proper activities or the activization measures, intergeneration initiatives, and so on and so forth. And I'm really happy to hear what you've been saying. We all are aging, we have an aging curve, and everybody will reach the senior age at some point. And that is why we need to find some sources of care for people who are not autonomous. One of you gave the German example of the care insurance, and this is one of the solutions also discussed in Poland. Myself, I said yesterday, we have excellent solutions, and these excellent solutions are then presented to the Minister of Health. But the Minister of Health says, listen, I need to fight with the fire. There's just one emergency after another. I don't have money. That is why a lot can be placed on local governments. And under this financial perspective, we can use the money made available. However, with some restrictions compared to the previous perspective, the prevention of the working population, the return to work things, well, these types of priorities will restrain our scope of action. Mental health programs could be, as far as I know, a priority for local governments, because this fosters a quicker return to work for patients, this will take place. Moreover, there will be other programs which are usually very, very popular and are a gauge of success. White spots and inequality in access to healthcare. You've mentioned that. Well, we all realize that the inequality in access to care is a result of several factors. Budget, shortages of staff, lack of offer on a specific territory. It's not that people do not want to use healthcare services, they simply don't have the possibility. Let's take an example of long-term care, inpatient long-term care. And here it is heavily region dependent. The life has shown that with good hygiene practices and nursing practices, people have a better quality of life and live longer, even if such inpatient long-term patient care. There is prevention and there is repair, medicine. All local governments, bottom up, should be actively involved in education, and this is one of our liabilities and weaknesses. For that, we have European budget, the European budget, and it's good that this budget has been made available. The local budget, the national budget, would be definitely insufficient to do any education campaigns. Any local government leader is ready to implement such initiatives, intergeneration programs, activization programs. Well, all of that will help them to win yet another election. So it's a natural thing to be ready to organize such types of programs. I'm the marshal. Well, I was introduced as a marshal. 4 years ago, I decided to quit my job at the level of the voivodeship. I came back to my medical practice, but I'm involved in the regional prevention programs. And we will have at our Union of Voivodeship a new health committee. We will do our best to attract local governments. We will try to attract their attention to programs of prevention. And this is a challenge, and it's unavoidable. Myself, I've had the opportunity to work with the National Prevention Center under the leadership of General Trybusz and Professor Gieralak. A very, very interesting program. The gaming methodology is used there, and that could be also of interest for local government. A toolbox, solid toolbox is available, and I think that the HTA agency should also play its part to assess the program. Let me give you an example. A small commune with a restricted budget, but let's hope they will get some more money for it to be able to implement health programs. Local politicians believe that it's better to lay down like some additional meters of pavement instead of investing in health programs. Our society needs to be aware, and without an informed society we could organize more and more congresses, and it will not give the results that we expect. Thank you very much. Professor said that awareness is an issue at stake, and we need to be aware of the demographic changes and that the age pyramid is becoming reversed. The Opole Voivodeship has been implementing an interesting initiative. It's about pregnant women and mother care. Could you please give us some more details about the care for mothers, future mothers and mothers of babies? In a way, this fosters also our fertility rate. This is an initiative implemented when some services, fertility services, were not available on the guaranteed package. So sonography during pregnancy, screening, prenatal testing, and so on and so forth. It's not that the agency said yes from the start. No, we had to improve, and we are in a constant dialogue with the agency. And the program is an extreme success. It's a success story. These services, healthcare services, were offered to mothers, future mothers, and to newborns, or rehabilitation services. And just to complement services which were not available in the guaranteed package. This program for families and for mothers was inspired by some experiences. Some years ago, we realized that we struggled with aging society. Then we had so-called Euro orphans, children left behind by the parents who decided to emigrate for work to other EU countries. And these children were taken care of, but not enough. Especially that these parents stay for long abroad and left behind also their old parents in the home country. And the state did not offer much, and that is why we decided to build a special demographic zone financed from the EU budget to show how to manage the aging process. And intergeneration initiatives were actually true stories of success. Then there are special funds at the level of local communities, civic programs. They are voted on, they are actually extremely resourceful, and they get the financing, and even if the budget is limited, the outcomes are really very, very satisfying. Right now we need to do our best to support the NGOs, and for that we also need the EU financing. So if the trend is positive for the local budget, we will manage, and local governments will manage and will better implement the tasks ahead. 5 minutes till the end of the session. One question to Director Siwiec, one question to Professor Podhorecka. Please be brief. And one to Director Edyta Masłowska-Parafian. Okay, so what should be done to broaden the scope of existing regional health programs? Just to go outside the scope of occupational health. Well, it's already programmed, and all programming documents are really there. And the Commission has issued opinions. Maybe during the midterm reviews, you could suggest something, and that's the only option, to make recommendations and then to introduce change to the programming documents. So that would be the best moment to propose changes. Well, for what has been programmed for regional health program, Well, you know, you have also other funding available from under different funds, and you can shift the money or reallocate the money left under different budgets just to complement the regional health program. And it's up to the steering committee. It's not easy, but if you really want it, it's possible. But it's still a challenge. And midterm reviews. Do you have any dates approximately? So it's a it's in the mid financial perspective. So it's 2025 and 2026. We started late, so right now we have the time to produce argumentation and prepare some substance to then request a change in the pre-programmed scope of actions. Yeah, we want to have as many health programs as possible. That would be my questions to the director from the HTA agency. So, what would be your recommendations? Well, progress, ladies and gentlemen. You said that there are different discrepancies between the programs implemented according to the template and the guidelines. It's 90% success, and programs which were implemented without the template or without the guideline, there the efficiency is 80%. So if you have such discrepancy, 90% on the one hand and 40% on the other hand, just follow the recommendation. This is also a motivation for us as agency to develop recommendations. Some of them were developed 5 years ago, so we would need a review of those produced in 2019 or 2020. And the extension of the catalogue will take place, better coaching, because that's your expectation, but you need to highlight more and stress more your needs. Our agency is local government friendly, believe me. It's true, it's not always the case with other agencies or other bodies, but we as the agency, we are open to work with local government. And we also have our academy. And the academy may organize education and coaching activities. And just to give you one argument, 30 years has passed since the adoption of the local government acts. And there are plenty of discussions about the split of tasks between different levels. The local government cannot buy healthcare services. And it may be a paradox, especially that some of the local authorities are the owners of hospitals or outpatient clinics. And for the wider scope of healthcare services, no, it's not wide, it's restricted. So, maybe there will be a modification of the act, and maybe the scope of services available for purchase, procurement by local government will be broadened. Maybe. But that's also the question of fairness. You know, there are communities which are wealthy. Kraków is a wealthy commune, a wealthy municipality. And Kraków definitely has much more opportunities than the commune of Liszki. So it will be good, probably, to have this option for local governments. But how to finance the same stomach? Well, there is always the same stomach. I'm against this solution. local government should not procure healthcare services. It will only deepen the inequalities. You see here the picture of stones. That's a beautiful image and symbol. But just have a look. If you put one more stone on this pile, something might happen. And I think that this new stone should be prevention. Today, it's not that much financed. I think that the largest stone in the pile represents or should represent the education. Without that, everything will stumble, fall down. We have a lot to catch up. The social awareness is extremely low, and I do not hesitate saying that we have a homo sovieticus in us. In other words, we count on other people without doing ourselves what we should or are supposed to do. It's co-responsibility, it's co-payment, and if you treat for free, you treat for nothing. Seniors, I think, can also get involved only if they see the benefits. So we need to convince them. In the Czech Republic, nobody finances physical activity of Czechs. Why? Because it's not needed. Czechs are physically active because they simply know that it's important. And for cyclists, all the protective equipment is not financed because Czechs are fully aware of the road safety rules. Right. Thank you. Professor, just one sentence of conclusion for our session. Ladies and gentlemen, I know that local governments play an important role in developing and implementing local health programs. It's a unique role. I believe that you become a key player in ensuring decent conditions of life for all the generations, the seniors, the younger generations. We all offer you our broad support, and we keep our fingers crossed for you. Yeah, we will be with you in this journey. We will climb with you through the steps of the ladder, prevention and treatment ladder. We have experts, we have new local government leaders, newly elected ones. It's just about going outside the silo and thinking out of the box. Thank you very much for the participation. Thank you to the participants online and present here. Thank you to all of you, and thank you to our public for attending our session. I forgot to ask whether there are questions in the room, but that would be a good starting point for our coffee break. And just one promotion, a piece of promotion. In 2004 in Krakow, we organized the HTA conference, and which helped us to define the program of our actions for the years to come. And actually, all the recommendations defined back then were implemented to some extent. And 20 years have passed, and this is still one of the largest conferences that have taken place in Poland so far. So as I said, this is a stepping stone for our coffee break. Thank you.